Good morning. How are you doing?
Good, good. All right. And you?
Good, good. Thank you. On behalf of Work Kuwait, we would like to welcome you and thank you for this opportunity. This is our third talk, and the topic for today is very interesting, very important for moms, sore nipples.
Indeed, very, very important.
We don't expect pain when we're trying to provide nutrition for the baby, building this beautiful relationship. It's the least we want on the list, right? Pain is one of the scariest things maybe for moms, other than not providing enough milk, and this is, I think, the hardest for moms who really want to breastfeed, and they try their best and they educate themselves, they read, they put the plan, and then there comes pain and they can't do it anymore. how
Yeah.
how how much do you see that in your clinic, Dr. Jack?
It's one of the three main problems that we see in the clinic, and along with not enough milk and a baby who is not latching on.
Yes, and they are all related, right? It's like a cycle.
It is like a cycle, and I think one of the main problems with this idea of mothers having sore nipples is that everybody seems to believe that it's normal to have sore nipples when you're breastfeeding, and this is clearly
Right,
not the
right.
case.
Yes. And how much that occurs, like how often do you see it?
If we see 16 mothers and babies in a single day, it's quite possible that 8 or 9 will have sore nipples. It doesn't necessarily mean that that's the only problem they have. They also have problems perhaps with the baby latching on or problems with milk supply, but it's a constant in many of the mothers that we see with breastfeeding problems.
What do you think the reason is?
I think the reason is that, first of all, we believe that it's normal to have sore nipples. And I think that that is far too common and absolutely wrong. It should not be a problem. One of the lactation consultants that works in Toronto, when she had her first baby, she said to the nurse, "You see, I don't have sore nipples." And the nurse said, "Well, you're just lucky." And I think that that is too much of the issue here, is that if the mothers have sore nipples, it's considered to be normal and nothing needs to be done. And that is really a
Yeah.
shame, because the earlier we fix the problem, which is the way the baby latches on, then the easier it is to fix.
Yes. And what do you think normalizes that type of struggle or suffering? Why is it normal? Why do you think, like, why do people think it's normal? Where did it start?
Well, I think the problem is that it is so common. And I would bet that most nurses that work in postpartum are women. And if they breastfed, they had sore nipples too. And so they feel that it's normal, but it's not normal. And the reason it's not normal is that the problem is almost 100% of the time that the baby is not latching on properly. And there are many issues
Mm.
involved here. So mothers don't seem to have as much milk in the first 3 or 4 days. And the thing is that if the mother's milk flow is very good, if the flow to the baby is very good, then the mother is less likely to have sore nipples. But in the first few days, most babies are not getting a lot from the breast. So if they don't latch on well, they get very little milk. If they get very little milk, they tend to slip down on the nipple and cause the mother pain. Hello? Are you there?
Yes, I'm with you. It's breaking. Yes, I'm there. Yes, it's breaking a little bit, but I could manage to have the idea together that it all started by people not aware about proper latching, and then many people having all of this sore nipples, which made it normal. And more problem happens because of them thinking it's okay because of too much milk at the beginning, so the baby is drinking well, and then like something that happens later, right? Like you're referring to late onset.
Well, yes, I'm referring to late onset decrease in milk supply, but also in the first few days, babies don't get a lot from the breast. And so if they don't latch on, they don't get a lot, so they slip down on the nipple, and that causes the mother pain. And so the pain in the first few days after birth is considered to be normal, and it's very, very common.
Yeah. And how do you fix it in your clinic?
Well, as I suggested, one of the problems is that we see these mothers much too late. The fixing of the latch can be done in the first day or two. And so if the baby gets a better latch during the first day or two after birth, then the mother has less pain, the baby gets more milk, and things will work out. The problem is that there's another problem involved here, and that is the fact that in Toronto, where I live and work, the majority of mothers have epidural anesthesia for labor and birth. And that gives them a lot of IV fluids. They often get 3 or 4 or even more liters of fluid in the first, during the labor and birth. And so the mother's breasts are, and whole body is overhydrated. Because the breasts are swollen from fluid, the baby has difficulty latching on. So the problem is that it becomes a vicious circle. The mother's breasts are difficult to latch onto, the baby doesn't latch on well, the mother has pain, then we start to give bottles, the bottle interferes with the way the baby latches on, and we have a vicious circle that results in many mothers failing to breastfeed because of all these issues. And they blame themselves, which is a big problem too.
Yes. So the first recommendation is try to stay away from IV fluids during birth, which means including epidurals and the things that, like these routines, right? It's not only epidural. Sometimes the IV fluids are just routines, even without epidural. Just like don't eat or drink and take these IV fluids to keep you hydrated, and that's it, right? So it's the epidural is one thing, and the IV fluids also, and
Yes, that's
early
right.
initiation and getting help early. So this is the top recommendation, right?
Right, because many mothers will suffer with sore nipples for a few days, maybe even a few weeks, but they don't have to. If they got
What is normal?
help, what is normal is not to have pain.
Not for a second, not in the beginning, not in the initiation, never.
That's right. As I said, one of the lactation consultants in Toronto, when she gave birth, she had no pain right from the very beginning, and she was told, oh, well, you're just lucky. As far as the IV fluids are concerned, even if the mother does not have an epidural, there is actually no reason that she can't eat and drink in labor. This was an old idea that, oh, no, you better not, in case you need a cesarean section. So don't eat or drink. And so the mothers were given IVs. And I think that if they've got an IV, that should be kept the minimum amount that's necessary. Because I don't think we're going to change the situation with epidurals in the next few years. It's a done thing. Everybody gets one. 90%, 95% of mothers giving birth in Toronto have epidurals. So instead of giving 3 or 4 liters in a 24-hour period, maybe we can just hold back a bit and not give so much, and maybe that will make a big difference.
So normal is not having pain at all, and there is this, like, sometimes old moms or people who breastfed before with a lot of pain, they're like, oh, if you don't feel any pain, that means the baby's not latching well, which is exactly the opposite. And because they had traumatic experience and with bleeding, with all of this difficulty, they will not expect anything other than this. So if there is no, like, then moms without pain will be worried that the baby is not latching. So it's even
That's
worse.
right. Yeah, that's right. And it's very important, therefore, what we talked about in the last talk, to know if the baby is getting milk from the breast, because a baby is not necessarily getting milk from the breast just because they've got the breast in their mouth and they make sucking movements. So learning how to know a baby's actually getting milk from the breast, if the mothers know this, then they won't start to worry, oh, my baby's not latched on properly, the baby is not getting milk from the breast, blah, blah, blah. And so that's all these myths about breastfeeding sort of come together to make mothers worry, to make mothers start to supplement, to make the nursing staff in the hospital and even lactation consultants to recommend supplementation. And I should jump in here and talk about tongue tie, because tongue tie is a reason for a baby not to latch on well. And what we see in Toronto is several hospitals where they say, oh, no, 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 tongue ties don't affect breastfeeding. Obviously, they don't know what they're talking about. But also, mothers are told, yes, 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 there is a tongue tie, but it's just a minor tongue tie. And so you don't need to do anything about it. And we see this all the time. And the question is not, is the tongue tie minor? Is it really bad? Is it something in between? You have pain, then something is wrong. Then the tongue tie may not be so minor as all that.
So the level of the tongue tie has nothing to do with the interference and effect on breastfeeding.
That's right. I mean, yes, yes and no, because we have seen mothers with with babies with very, very severe tongue ties. Even a pediatrician could make a diagnosis of this tongue tie. It's so obvious. And they have no pain, and the baby is breastfeeding well, and everything is going fine. But this is the situation where we sometimes see late onset decreased milk supply, because if a baby doesn't latch on well, and they cannot latch on well with a tongue tie, then the milk supply may decrease in the next month or so, or even longer.
So your recommendation for obvious tongue ties, even if there is no direct effect on breastfeeding, is to flip it anyway, because that will cause late onset, right?
Well, it may not always cause late onset. So if we see such a mother in our clinic, we will give her the choice. We'll say, we can release the tongue tie, even though you have no problems, or we can tell you, here's what you need to watch out for over the next weeks and months. Here just are the signs of the baby not getting milk from the breast well, even if the baby is gaining weight well, because these mothers who are doing fine, even with a severe tongue tie in the baby, they usually have a lot of milk. And if they have a lot of milk, then everything may seem fine. So here's what you need to watch out for. Baby getting fussy at the breast, baby getting fuzzy between feedings, baby sucking their fingers all the time. Mother's starting to get a new pain in breastfeeding. Why? Again, because the baby, if the milk supply is decreasing, even though the baby's still gaining weight well, if the milk supply is decreasing, then the baby may slip down on the nipple and start a new nipple pain for the mother. Even sometimes a mother who never had pain before.
So babies don't grow out of tongue ties.
I guess not. I still have mine. I still have a tongue tie. Yep. And many adults still have tongue ties, but they tend to get better with time, the tongue ties. Maybe not in everybody, because I'm an example, but it's certainly a lot of babies we see at 6 months who give a history of having a significant tongue tie. Excuse me. Significant tongue tie. Really, when we see them at 6 or 7 months, the tongue tie is not so bad. So it's hard to know. And the other issue that with tongue ties, if they're severe, is that can affect eating solid food. It can affect pronunciation of words in several languages. English is not a big problem for pronunciation, but many languages, for example, where you have a rolled R, like Spanish, I think Arabic, yes, you have a rolled R that I can't pronounce because I have a tongue tie. It becomes an issue. And in many languages, in English, you know, how people pronounce is not always a big deal, because you know, there's so many people around the world that speak English as their first language in Britain and Canada, United States, and Australia, New Zealand, South Africa. Uh, all these countries have different accents, and so people say, ah, you know, okay, so they can't pronounce an R. We don't have this rolled R in English. And so it doesn't seem to make that much of a difference. But in many other countries, if you don't pronounce just so, people think you're strange. And so we've had, for example, a family that came from Serbia. And the father, when I said the baby's got a tongue tie, he didn't even ask questions. He said, okay, then just cut it. And why? He said, because when he was a child, all the children mocked him because he could not roll an R. And at the age of 25, he had his tongue tie release, and then he could start rolling his R's.
Yeah. It's a very, very interesting topic. And now we are living in this time where there are more ties that are being explored, like the lower lip tie, the cheek buckles. What's your say on that?
Well, a lower lip tie, I'm not sure how that would affect breastfeeding. And the buckle ties, I don't know what to make of that. I think that we see it from time to time, and I just think that already we're having huge problems with pediatricians mocking mothers who are saying, oh, my baby has a tongue tie. And I think if we start adding more and more possible ties, then we will run into big problems. I think that what we see in our clinic is most of the time, releasing a tongue tie makes a big difference, not only for the mother's pain, but also for the amount of milk the baby gets. But the earlier this happens, the better that the tongue tie is released. And there are people who recommend releasing tongue ties on day one after the baby's birth. I don't want to comment on that because I'm not in that situation. I don't see mothers and babies immediately after birth.
So do you have an ideal time?
I would say that if the mother's pain is significant, 3 or 4 days after birth, that's the time.
Yeah. And tell me about the small percent of moms who would release the baby's tongue tie, get it released, and still have pain.
Well, again, we see a lot of mothers whose babies have had tongue tie releases, but they have not been done properly. Mm-hmm. Often they just snip maybe a millimeter of the tongue tie, or the tongue tie has reattached, and they do reattach. I'm guessing we have a reattachment rate of 20–25%, but sometimes even the reattachment is not, most of the time the reattachment is not as bad as it was before, and so often the mothers have significant relief anyway, but not always. And so, you know, it comes to the situation of, well, we need to do this again. And that's not easy for parents to enjoy as an idea. And so we, you know, sometimes we don't do it. We try to use other methods. So there are other things that we use to help mothers with pain. I mean, we have what I call my all-purpose nipple ointment, or APNO, which is a pretty good treatment, but we don't want mothers to be using them for the entire time they're breastfeeding. So we need to do other things, and tongue ties are not the only cause of a less than adequate latch. So, you know, we work on the latch, we try other things. One of the other causes of sore nipples is what we call vasospasm or Raynaud phenomenon. And this is not an uncommon problem. And it also occurs in summer, not just in winter here. So it's caused by a constriction of the blood vessels that go to the nipple. And this causes severe pain, often blanching after the feeding is over, blanching of the nipple after the feeding is over. And then it can continue for quite a period of time after the baby is already off the breast. And so there is treatment for this. The first treatment is to fix the latch. Even if the problem is vasospasm, then often the latch is not as good as it should be. But if it's really severe, then we will often treat these mothers with long-acting nifedipine, which is a vasodilator and is used for Raynaud's phenomenon or for vasospasm. For example, in women that have lupus erythematosus and have vasospasm of their fingers and toes. So it does work, but we find that most of the time fixing the way the baby latches on is probably the best way to deal with vasospasm. We fix the cause of the problem, that is the way the baby's latching on, then the vasospasm usually goes away as well, although it may take a few extra days, maybe a week longer to go away.
So if the mom has vasospasm, okay, is she going to have cracks or only sore nipples as in pain?
She may have cracks, but that's not the cause. It's the vasospasm, the cause of the blood vessels going into spasm. And mothers can have this, or I mean, I've heard of a number of mothers who have had this during the pregnancy, even though they've never breastfed yet. So it's possible to have this for reasons that we don't always understand.
Yes, because I'm wondering that, to be honest, as a lactation consultant who is not from a medical background, where can I get this done? Because we don't have that practice here in Kuwait, to my knowledge, and that's something that I would personally wonder, who is it, like, who can do this?
Well, we often use what do we use? It slips my mind right now, but we use something that you don't need a prescription for. For example, I'm just trying to think of what it is. I will get back to you on this, unless you can give me 2 seconds to check my sheet on. It's on the sheet that's called sore nipples or sore breasts, and it discusses what can be done for vasospasm. I mean, we have published an article from our clinic that shows that mothers, if they do this sort of thing just above and around the breast, that will often help for vasospasm, and it does, but it is temporary, and so we prefer to use nifedipine if the massage, the pectoral massage, does not work. There's more information about it on our website. On our website, under sore nipples and under sore breasts, for that matter, we talk about an article that we published from our clinic where the mothers use pectoral massage to decrease the vasospasm. And it's described very well on our information sheet. So it's something that mothers can do, but again, it's only temporary. So again, we need to help the mother with the latch so she doesn't have pain during the feeding, and also the pectoral massage to give temporary relief. And if that doesn't work, then the nifedipine is often very useful.
So this is very important, especially for moms who've done everything. They've seen a lactation consultant, they're trying to get asymmetric latch, they have done already, they went and clipped the baby's tongue tie, and they still have pain.
Yeah.
What is your say on a high arch?
A palate.
Yes, a palate.
I don't talk about it very much. I think it's a useless thing to tell the mothers because there's nothing you can do about it, right? You do an operation on the baby's palate? And I think that the high arched palate is a sign of a tongue tie. So I don't think that there really is necessarily something to talk about high arched palates, because it doesn't make any sense. It's like me, what am I going to do about not having hair here? I mean, there's not much to do. So I forget about it, right? And the same thing with high arch palate. Why talk about something about which you cannot do anything about?
So any physiotherapy or any occupational therapy that is recommended, or nothing, right?
Well, our lactation consultants actually really like the physiotherapy or the help that mothers can get with helping the baby to get better relaxed muscles so that the mother does not have pain. I think that I don't know how well that works. Here, it's covered by insurance for most mothers, not all. And so I don't know enough about it to really say it's definitely good, it's definitely bad. Our lactation consultants really believe in it, and that's fine. I'm not saying it's not doesn't work or it's not helpful, but I think that you know, these other things also are necessary. That is, really fix the latch. And as I said earlier, a baby with a tongue tie cannot have a good latch. So those things need to be dealt with first because they take less time.
That's very, very interesting and very important for moms, especially that we see it more often. Do you think that, like, why is it more than before? Do you think it's because we now know more that there's a tongue tie, so we're like over-diagnosing, or like, why is it new? Why people are not believing in this?
The tongue tie.
Yeah.
Is that what you're asking about, the tongue tie? No, it's not so new. I have an article from Germany in 1847 where the author describes tongue tie and how it interferes with breastfeeding. Midwives in the UK, in the United Kingdom, have been releasing tongue ties with their fingernails for years. I don't think it's such a new thing, and it's one of those things that we've forgotten about. It's basically, you know, mothers were not breastfeeding in North America, in much of Europe, for, you know, generations, from the 1930s to the 1970s. Very few women were breastfeeding. And so we just forgot about breastfeeding and how it works and what causes problems and how to fix the problems. It's all for, you know, the 1970s, not that long ago. And so we only started to change what happened in 1972, for example. It was 1970, 1971. Only about 20% of women, 25% of women were even initiating breastfeeding. All the rest were bottle feeding. So we forgot about what's normal. We forgot about what's abnormal. And so this whole notion that breastfeeding is supposed to hurt came from a whole different era.
Yes, we were formula feeding for so long that we forgot how breastfeeding is supposed to be. It's very, I think it's very important for us to let go of the old thinking and how, like, from the 70s we used to do things, and be more open towards fixing things and trusting how we feel. If I'm feeling pain, and if I know that pain is not normal, I mean, I shouldn't be expecting that it's okay for me to be in pain for 2 years and that's how things are supposed to be, right? It's just not
Right.
instinctual. It's not normal for things
That's
to
right.
happen for that long. And like, in birth there is a purpose of this pain, and there is a way to deal with it, and it's temporary, right?
It's
It's
temporary. And I think that one of the things that we forget about having pain during labor and birth is that when the baby is born, the mother's pain goes away. And she associates the new baby with the lack of pain that she has. And so it's like a strong stimulus to bond with that baby. The pain went away. Now I have this baby. This is perfect. But with breastfeeding, pain offers no purpose except to stop mothers from breastfeeding, unfortunately.
Do you have any last advice that you would give us?
I think the most important advice is to get good help early. Don't wait. You know, mothers were often told it's normal to have sore nipples for 3 weeks. It's not normal to have sore nipples for 3 weeks. So let's get on this problem immediately. Yes, it's true. Sometimes the pain did go away within the first 3 weeks, but why should mothers suffer for 3 weeks anyway?
and it has consequences. Not only so, the pain is not something, okay, I will suffer, I will take this, I will sacrifice for my baby, but they don't realize that the consequences are huge. The baby not having enough milk, the baby not growing, dropping the weight, and then supplementing. And this is not what they see at the beginning, right? So it's not
That's
about
right.
moms taking it or just going through the 3 weeks. Okay, we're about to finish. No, the consequences are bigger than this.
Exactly.
It's not selfish for a mom to have the baby's sanctuary release. It's not selfish. She's not doing this for her. And like,
She's doing it for the
yes, it's
baby
not.
too.
Yes, exactly. Because a lot of moms have this guilt that no, I don't want my baby to suffer. It's okay, I will take it, and that's not accurate. There are so many other factors that are in the benefit of the baby as well. Thank you so much,
Exactly.
Dr. Jack Newman. Thank you so much. It's really a pleasure to have you, and we are looking forward to uh, have more talks and more topics.
Okay. Thank you, Nour Zaza.
Thank
It's
you.
been a pleasure. Bye bye.
My pleasure. Bye bye.